There are also some non-hemorrhagic fevers that we need to talk about as well. Unlike the hemorrhagic fevers, non-hemorrhagic fevers do not cause rapid bleeding. They are going to be characterized by high fever states, but they don't have that capillary fragility that's associated with the typical hemorrhagic fevers. All the diseases that are caused by the non-hemorrhagic fevers that we discussed are going to be caused by bacterial sources. We have brucellosis or brucellosis. This is also known as the Malta fever, undulant fever, and Bang's disease. This disease causes very severe outbreaks of placental infections in livestock and can cause an increase in the rate of stillborn livestock. This disease is also being listed as a possible bioterrorism agent. It's caused, or brucella is bacterium that can live within our phagocytotic cells. So our phagocytotic cells, these lymphocytes that normally will phagocytize pathogens that make it into our body, are actually the preferred living site of this bacterium. And these phagocytotically active cells are going to phagocytize the bacterium. The bacterium can then live and continue to reproduce within the phagocytotically active cell. And that cell, that phagocyte, will then carry the bacterium to our bloodstream. This is going to cause the formation of lesions in the liver, spleen, bone marrow, and kidney as this bacterium continues to reproduce. The primary manifestation of brucellosis within human beings is going to be a fluctuating pattern of fever, hence the name undulant fever. The fever, or the body temperature, undulates up and down, kind of like the waves in on an ocean. The bacterium that causes it is Brucella, genus Brucella. There are several different species, Brucella melantinus, Brucella abortus, and Brucella suis can all cause this disease within human beings. All of the Brucella species are going to be tiny gram-negative coccobacilli that thrive in an aerobic environment. They need to have a lot of oxygen present. The primary manifestation of Brucella in animals is that the placenta and fetus is going to be infected within animals. Thankfully, human placentas cannot become infected by this disease. So that reduces the risk of stillborn birth or miscarriage within human beings that are infected. Up next we have Q fever. Q fever is kind of a tongue-in-cheek name. We are not talking about the Q from Star Trek The Next Generation. We are calling it Q fever because Q stands for query. We were asking lots of questions or queries about this disease, trying to figure out what the heck causes this disease. And it wasn't until the mid-1900s that the Coxiella brunetti was identified. This disease is characterized by having a very rapid onset of fever and chills associated with head aches, muscle aches, and occasionally arrests. So general malaise, so to speak. This disease can be complicated or compounded by the fact that 30% of the cases also are going to be associated with pneumonia, hepatitis, and endocarditis as well. So this is very rarely a disease that stands alone. If we look at this, a quarter of the cases are going to be chronic rather than acute. So these are going to be in cases that are going to last for a very long period of time with milder symptoms as opposed to a short period of time with very pronounced symptoms. And a quarter of those cases are going to result in vascular damage that will mimic endocarditis. This mimicking of endocarditis was one of the reasons why it was so difficult to initially diagnose or identify the pathogen that causes Q fever. This pathogen is Coxiella brunetti. It's a pleomorphic gram-negative bacterium. What do I mean by pleomorphic? I mean that it can alternate body shapes or cell shape. It can be cocci, it can be bacilli, it can be spiroret. This is a bacterium that can change shape. It's, for a while, was considered Rickettsia. However, it was recategorized as Coxiella brunetti as more was learned about it. This bacterium is another intracellular parasite. Intracellular parasite, meaning this bacterium can thrive and live within a human host. This is unique. Most bacterium are going to be extracellular parasites, whereas the viruses that we've talked about are typically going to be the intracellular parasites. This is one of the exceptions to the rule, and that is a bacterium that is an intracellular parasite, just like the previous bacterium that we've talked about, our Brucella. Q fever is harbored primarily in vertebrates and arthropods, so it's going to be harbored in many different organisms. If we look at the arthropod vectors or arthrovectors, ticks in particular play a very special role in the transmission of this disease between a wild reservoir and a domestic reservoir. Ticks themselves, though, do not directly transmit this disease to humans. That is worth noting. This is one of the few diseases that can be carried by a tick but not given to a human. Humans, however, are going to acquire this infection as we are exposed to environmental contaminations and airborne spread. So if you're around the birth products of an animal that's been infected, such as the placenta, or if you're around a desiccated or domesticated animal that contains a high rate of infection or a large number of bacteria, those bacteria are going to be shed, and you can pick them up that way. It's also possible to pick up this disease by exposure to urine, feces, milk, or any airborne particles from an animal that's been infected. Generally speaking, this is going to be domesticated livestock that's infected. So anyone who spends a lot of time around animals, farm workers, meat cutters, veterinarians, lab techs, or consumers of raw, unpasteurized, I'll emphasize again, unpasteurized milk products, are generally speaking going to be at risk of developing this disease. How can we prevent and or treat this disease? Well, if we have a mild case of it, or a subclinical case, a case that doesn't merit going to the doctor's office, generally speaking, it's going to resolve all by itself. Our body's capable of fighting it off. However, if a severe or acute case is found, we are going to typically treat it with doxycycline. It is possible to get a vaccine for this disease. However, this vaccine is not currently approved for use within the United States by the Food and Drug Administration. Up next, we have cat scratch disease. Cat scratch disease is typically going to be associated with being clawed or bitten by a cat, and the signs and symptoms are going to manifest themselves 1 to 2 weeks after that initial perforation of the skin by the feline. At that site of inoculation, there are going to be small papules that will begin to grow, and most of the infections that are going to manifest themselves within humans remain localized. So those papules don't spread systemically, and instead are going to remain around the wound site and will resolve themselves within a few weeks. Cat scratch fever is caused by Bartonella henselae. This is a very tiny gram-negative rod-shaped bacterium. This is also a fastidious bacterium. When I say fastidious here, I mean that it's very picky about its growth environments. Because this bacterium is fastidious, it is particularly difficult to culture or grow within a laboratory setting. And generally speaking, it's not going to be used in an undergraduate micro course because it's such a nitpicky bacterium. It's not an obligate intracellular parasite, so it is possible for it to grow on blood agar. Generally speaking, this pathogen is present in about half of the cats in the United States, or 40% of the cats in the States, but especially within kitten populations. There are approximately 25,000 cases of cat scratch fever every year within the United States. Most of those cases, the vast majority of those cases, are going to be in populations that are at increased risk of getting scratched or bitten by a cat, so 2 to 14-year-olds, with a higher emphasis towards that toddler age range of the spectrum, because those are the young children that are learning how to play nice with cats and oftentimes get clawed or bit by cats as they're learning to play nice with those kitties. To treat this disease, the erythromycin, and rifampin can all work against this because it's a gram-negative pathogen. This disease can also be prevented with aseptic cleansing of the wound site very quickly or very soon after the initial bite or scratch. We also are going to chat about Rocky Mountain spotted fever. This is another non-hemorrhagic fever disease. This particular disease will manifest itself 2 to 4 days after initial inoculation. The symptoms associated with it are fevers, chills, headache, and muscular pain. So pretty much the same generic symptoms that are going to be associated with most of the other diseases that we're talking about here. The distinctive spotted rash, though, that tells you have Rocky Mountain spotted fever, typically is going to occur 2 to 4 days after the prodrome. These early lesions are very small and are mottled, just like a case of measles. However, as these lesions or the disease progresses, the lesions are going to continue to grow and become macular, macular-popular, and petechial. In particularly bad untreated cases, these enlarged lesions can actually become necrotic, so the tissue can start to die, and this will predispose the patient to get the development of gangrene within their toes or fingertips. Some other signs or symptoms associated with Rocky Mountain spotted fever also include cardiovascular dysfunction, hypotension, so low blood pressure, thrombosis, and hemorrhage. These conditions don't necessarily always manifest themselves. These are the most grave manifestations, so in very severe cases. Generally speaking, most patients don't have that hemorrhaging occur, so this Rocky Mountain spotted fever is going to be categorized as a non-hemorrhagic fever. In patients that have the disease well established within their bodies, there can be delirium, convulsions, tremor, and coma. These are typically going to be signs of the overwhelming effect that this bacterium has on the central nervous system of the patients. In approximately 20% of untreated patients, there will be a fatality, but treatment lowers that fatality rate down to 5%. So treatment increases the likelihood of living through this disease by 15%. To transmit and spread the Rocky Mountain spotted fever, we're typically going to look at ticks as an arbor vector that will spread it. It's going to typically be, it's been named, I should say, for the region within the United States where it was first detected. This region is the Rocky Mountain. It occurs very infrequently in the western United States, even though it's named for the Rocky Mountains. Most of the cases are going to be in both either the southeast or eastern seaboard regions. It can also occur within Canada, Central America, and South America as well. These infections are going to occur in the spring and summer when that arbor vector, that tick, is most active. There are almost no cases within the fall and essentially 0 cases within the winter when ticks go dormant. Every year, Rocky Mountain spotted fever is going to have approximately 20 to 40 cases for every 10,000 people within the population. So we're looking at 0.2 to 0.4% of the United States population, or less than 1% of the United States population, will develop Rocky Mountain spotted fever in any given year. There are going to be some fluctuations on an annual basis based on the weather and how accommodating that weather is for the preferred arbor vector, the tick. The pathogen that causes Rocky Mountain spotted fever is Rickettsia rickettsii. This is transmitted by ticks. And it's transmitted by hard ticks, Lone Star ticks, or Texas ticks, and the American dog tick. So that even if you're at a different part of the United States that has a different tick population, it is still probable that you can contract this disease because it can be transmitted by such a wide variety of tick species. To culture and diagnose this pathogen, we first need to isolate rickettsias from the patient's blood samples. This is desirable to do, but it's very expensive and requires qualified lab personnel and some specialized facilities. It's also possible to collect a sample from a rash lesion and use a PCR followed by electrophoresis to analyze the DNA fragments to confirm the presence of the bacterium Rickettsia rickettsii. This particular method is quicker and cheaper. Generally speaking, our drug of choice is going to be doxycycline, and that's going to be administered for 1 week. And this is going to be used whether it's suspected or confirmed that Rocky Mountain spotted fever is the pathogen or the disease in question. The preventative measures for Rocky Mountain spotted fever are going to parallel those for Lyme's disease. Recall, Lyme's disease is another disease that is characteristically transmitted by ticks. So the same methods for preventing tick bite will apply. Wear protective clothing. Wear boots have your pants tucked into your socks and wear pants as opposed to shorts. Use insecticides on your body, and then if you find any ticks, fastidiously or using particular care and precision, remove the ticks from your body. So to review, we have our non-hemorrhagic fevers. We have brucellosis, Q fever, cat scratch disease, and Rocky Mountain spotted fever. Oof, that's a mouthful right there. So concept check class. A non-hemorrhagic fever is characterized by blinkety-blink blood capillaries and body temperatures. Would it be fragile blood capillaries, normal body temperature, normal blood capillaries, elevated body temperature, normal blood capillaries, normal body temperature, or fragile blood capillaries and elevated body temperature? Go ahead and rewind the PowerPoint to find me an answer, or you can check your notes and or your textbook. 4, 3, 2, 1. Non-hemorrhagic fevers are characterized by B, normal blood capillaries and elevated body temperatures. If you have any questions about this material, please feel free to post them in the class discussion board or shoot me an email. Happy studies.